Hi, we're back, everybody, for episode 4, that was fast, of the Future Proof PT podcast. And Alex and I are going to talk about a couple of topics today. We thought first cover what's happening on the Hill. Things are moving fast and slow in Congress. I thought I'd just give sort of an overview of what that means and what therapists should care about, what could or couldn't happen in Congress in the next few weeks through few months. And then we thought we'd cover the categories of alternative payment models. And Alex did a really awesome job breaking down the different types of models from a musculoskeletal care perspective. And then maybe we can have a dialogue about how each of those sort of fits into the healthcare industry's perspective on alternative payment models. Does that sound good?
Sounds terrific. And I think luckily we will be able to package it in 55 minutes or less for our dear audience to be able to consume it and regurgitate it by Monday. Looking forward to hearing your explanation, and also looking forward to learning as we go as well.
Awesome. Okay, so there's a lot being thrown around right now, budget resolutions and budget reconciliations and continuing resolutions and debt ceilings and government shutdowns. So just to give an idea of what these terms mean, super high level, as of today or a couple of days ago, the House passed what they call a budget resolution. And that budget resolution says each of the committees of jurisdiction in the House of Representatives has agreed to a dollar amount that they have to cut from what they're responsible for. So the Energy and Commerce Committee has to cut X amount. I think it's $880 billion. And the week before that, the Senate did the same thing, except they decided that they're just going to do a small bill. They said, we don't want to take on everything. We don't want to take on taxes. So instead, we're just going to take on defense and energy and the border. So the Senate passed this smaller budget resolution. Now the Senate and the House have two different budget resolutions, and they have to now come together and decide what is going to be the final dollar amount. So there's a lot that still has to happen, and nobody has made any decisions yet about where that money is going to come from.
Yeah, so it sounds like there's a remainder of contingencies that have to be resolved for this process to be finalized. And the constraints of this process is the actual polarization on a higher level and lack of desire to come to a common ground, right? What do you think are these contingencies that are easy to resolve from your stand?
What the Senate has decided on is the easy components to resolve, right? So one option is the House decides to break down into two bills, but President Trump told the House he wants one big, beautiful bill. So he wants everything covered in one budget reconciliation bill. He doesn't want to do two. But this year, two are allowed. So the Senate's decided we want to do a smaller bill, pass a budget reconciliation, and then taxes, maybe when we're tackling the debt ceiling, right? So if the House and the Senate now have to decide what's next, the challenge is that what the House has come up with is going to require really big cuts. The president is saying we're not going to touch Medicare, we're not going to touch Medicaid, we're not going to touch Social Security. It's difficult to find money in those categories when we're not touching it. So it's going to be interesting to see where they come up with the money that they can cut. So that's really the big hang up is we want to pass the Trump tax cuts. That's their goal, the administration's goal. But it's hard if we can't figure out where the money's going to come from. So then we can jump to the debt ceiling. So somewhere in the summer, we have to raise the debt ceiling so they could raise the debt ceiling and just borrow more and pass more spending and pass the tax cuts that way, right? Increasing the amount that we're allowed to borrow. Then in the meantime, we also have to deal with the continuing resolution. We passed this 3-month continuing resolution. And so why that's meaningful for therapists is the telehealth extender, so allowing telehealth by physical therapists and other therapists, and allowing the expansion of telehealth in fee-for-service to be able to allow someone to be in their home and receive telehealth. That is completely dependent on congressional action and congressional funding, and it expires March 31st. The rest of the continuing resolution, except for a few healthcare things, expires March 14th. So if the two houses of Congress and both parties can't agree, then the government will shut down. That's a possibility.
So then I will play a naive fool and sitting in my comfort of my lazy boy, and I will give the same defense that you always hear being given. How does this concern me? What happens? What happens in Washington stays in Washington. How is it going to impact my clinic, my organization in New Mexico or in Minnesota or in South Dakota, right?
Mm-hmm.
It's relevant to my daily operation. Is this going to concern me at all, or is my life going to be as usual come April or May or June? Especially for clinics, because if you that don't actively engage in telehealth, unfortunately, that our telehealth utilization as an industry has gone down systematically year after year since 2020. So the fact that we're not using it, we're almost following that use it or lose it attrition, right? So how does it affect me?
Mm-hmm. So, two-part answer. When it comes to just having no budget and the government running out of money and there being a government shutdown, there are still things that have to be paid, even though the government shuts down. So there will be activity that stops, but physicians and those that bill for services are still supposed to be paid. So that's one component. The shutdowns usually don't last long when they happen to begin with, but we're in a very interesting time where there's very little bipartisan collaboration. When it comes to telehealth, right? If you're doing telehealth at all as a therapist, you're only doing it because it's allowed under the congressional expansion of telehealth. So that's part one. If we get to March 1st and we don't have a new funding and it's really legal authority, then physical therapists cannot use telehealth for any reason under Medicare fee-for-service, and most Medicare Advantage plans likely also are not allowing that because they follow fee-for-service usually. So again, do we just want to follow whether or not by March 31st, there is a continuing resolution that's passed that extends telehealth, which should include all the extenders of the types of providers. So that includes therapists, that includes FQHCs, and a couple other provider types that normally, right, under normal law are not covered. And covering us, the problem with covering permanently is it's expensive. So there is that piece. And then there's the last thing is the physician fee schedule issues, right? So something that therapists talk a lot about online. The conversion factor cut, there was a lot of agreement at the end of the year by everyone on the Hill, bipartisan, bicameral, both houses of Congress agreed to a physician fee schedule fix for the year with plans to have a different solution in the future. So we're in a place where everyone billing the physician fee schedule is taking the cut from the conversion factor. And what I think is interesting for therapists to think about when we talk about the conversion factor, a fix to the conversion factor is not a really high cost for them if it was just therapists, right? If it's a 3%, let's just give a round number, 3% for therapists, and their income is a relatively small amount of money, and we make up a small amount of the physician fee schedule. But for specialists that make up the majority of billing under Medicare Part B, if you have a specialist making 4 times what a therapist makes and many more of them, that's why the price tag is so big. It's not like they can pass a conversion factor fix just for therapists, right? CMS could change the weight of the codes for therapists, but they're passing a budget for a physician fee schedule. We're this tiny, tiny piece of it. And then CMS decides who gets what money, right? I think the opportunity is more along the lines of working with a Center for Medicare on potentially the weight of the codes that are used by therapists and making the argument that we are primary care providers and should be a part of the thinking about how to fund primary care better.
It's interesting, and correct me if I'm wrong, but this follows that supply-based economics where there's a natural precipitating decline in price with a higher availability of resource. Is there any relevance to this where it's like as the government tries to balance the price of the supply to match the demand for the specific service and then adjust the pricing so that it's balanced, we're falling into the trap of not really understanding the system well. All things considered, that the utilization parameters as they are will lead someone to understand only half the system, that we have to cut the prices because we're overutilizing.
I think therapists have an opportunity to present therapy services as underutilization and as the preferred utilizer of services that address musculoskeletal complaints at the first touch. We all know we have direct access, but we are not being accessed by patients as first providers. And so going back to a lot of the theme we talk about, if our codes are more heavily weighted as one opportunity, and if we are working alongside and part of advanced primary care teams, right, we are an efficient and smart way to address musculoskeletal complaints at the primary care level, rather than see the primary care physician who, by and large, most of their opportunity is to refer to additional services other than prescribing medications, right, and doing imaging.
Yeah, that makes sense. I think considering our place and our current footing, how viable is that of an option, and how much stress and how much effort would it take for us as a country to actually operationalize this on a large level? With all things considered, again, if we go into the constraints and contingencies, the contingency is that we don't have a single U.S. payer system, even though it's being classified as such, right? Even the federal payer system is regional. The regionality of it is going to create probably these windows of overutilization and underutilization, and the regionality is also going to create these vacuums or these deserts of care based on this, only because of the resources that are available. What do we do to build an infrastructure in that 5 years to make ourselves candidates to step into this primary care model?
To first go to the beginning of what you said, because I think that clarification is helpful. There is a large underutilization of physical therapy and other therapy services in terms of how many patients we touch and at what point we touch them, right? Many more patients, much higher percentage than I think therapists realize. We're missing because we just never see them. And then that's an underutilization of therapy as an industry, as a way of addressing, as a nation, musculoskeletal primary complaints, right? And then there's the overutilization driven by volumes of visits and codes being billed when patients do get to therapy. So in my mind, the future state is this. We are seeing patients when they're easier to treat earlier on, truly as first touch. And as part of where patients are already accessing care, we need to have many more therapists working directly in partnership and even in the same offices with physicians and behavioral health providers to treat the whole person. In the meantime, we should be thinking really hard about the dosing of our care. And just like physicians have been straddling this fee-for-service and value-based care billing systems where they're very incentivized to do more, right? We're not incentivized in fee-for-service. Nobody gives you anything for seeing someone less. And for therapists, right, when we're thinking about the frequency that we're seeing patients, are we really thinking to ourselves, do I need to see this person again this week or tomorrow or the next day? Or is it equally good or better, right, to have a phone call follow-up after the visit to give them a prescribed set of therapeutic exercises and to see them again in a week, maybe have a remote visit in between? In my mind, opinion, the only way therapy is going to survive and become what it could be, many more touches to the patient, and many more patients, but a more logical, patient-specific frequency and intensity of care, then we're going to lose our place, right? We're going to lose our place in a world of attention and efficiency and what makes sense. And in a value-based world, we're looking for things to make the most sense for patients and for the health system. In healthcare delivery systems payers.
I think that is very well said, Dana, and there's a lot to unpack there too. And probably the biggest, highest, most overarching theme is a dose response for an active therapy and capitalizing on this optimal dose response. And I've spent probably close to a decade trying to figure this out, and I'm still in loss for words whether there's a one gold standard or one source of truth for what is a gold standard for this. And why don't we even go easier for this outpatient orthopedic physical therapy that involves non-operative musculoskeletal conditions. You have had an abundance of empirical inquiry into the dose response for the bread and butter of physical therapy diagnoses for that your neck, back, shoulder pain. You have had inquiry into an optimal dose response for outpatient physical therapy based on timing. And there is no single source of truth beyond the fact that we, again, as you have referenced, we're good resource as a primary care option because when we are encountered, people generally tend to not ensue other healthcare expenses. There's also a pretty well-defined characteristic that when we are the primary and the first source of clinical encounter, there's also a lower downstream effect, lower rates of chronification, smaller economic impact, smaller social impact, smaller disability impact. But that still doesn't say anything about what we are as a discipline, because if you can't establish a dose response, to use a reference, in a phase transition, like you can measure the volume of ice easier than the volume of water, and that is easier to measure than the volume of vapor. Now, because when vapor just gas as a phase, right, it's omnipresent, and unless you have a really controlled environment, you can't measure it accurately or as accurately as when you can measure a solid, which is it's just much, much easier to objectify. And then even liquid is easier to objectify because it's still constrained by its composition. So I think right now, physical therapy we are there. We know we're substantiated because we're present, but we don't have the constraints to measure our objective fit into the model compared to what we need to be, which we need to be at least water, at least give us some constraints, some boundaries, some guidelines. And then ideally, right, we can be ice because there is enough tools to solidify, to congeal our nature into a solid state of profession. But there's just there's not happening, right? At least in my 22 years experience, it's not happening. It's maybe happening in the future. There may be some leaders within our field that are rising that have the solution, but it's not there. But so then once again, to go back, in theory, it makes absolute sense to use us as that model. But in practice, it will be really hard considering that just large and poorly controlled spectrum of practice that we right now encounter in the United States from just our discipline.
100% true. You are great with metaphors, Alex. You come up with them very quickly, and it's impressive. It helps people remember things. I appreciate it.
Right, but thank you for that. It really is a way of seeing us as a nature, as a physical being, right? And seeing where we can be. Again, if you're going to use another metaphor, right? There's usually an energy transference when you go from one phase to another. So who's going to supply this energy? And then right? It's energy is neither lost nor gained. I guess create better controlled economics towards U.S. healthcare because of that runaway spend. But when done so without a proper measure, without proper optics on what's actually relevant and important, you have some errors that are going to be committed because you're going to cut from things that really can't be cut, that are already thin, and then things that can be cut subjectively are going to be kept as they are because they're just probably better, more controlled.
I think along those lines, the question that I hear a lot is, how could CMS cut the conversion factor? Why is this happening? And, if we think about the volume problem, too much of some things and not enough of another, and this imbalance of where we really should be providing care, at what time period, how much of it, right? There's a budget, and that budget for the physician fee schedule payment every year is blown out of the water. Right? For years and years, there was one system, the SGR system was replaced with MACRA. We still can't ever hit the budget. And so what happens is the only way to hit the budget is to cut the multiplier so that it fits, so the dollars make sense and they fit. Congress has to allocate more money if we want to just keep spending money. But we know that when we look at outcomes, we look at life expectancy, and we look at our quality on many measures compared to the rest of the world, we keep spending more money, but we're not getting any better outcomes, and in fact, far worse than our peers. And so from a logic standpoint, when we complain about the conversion factor cuts, everyone who's utilizing billing codes in ways that are not the most efficient, understanding why they do, because we have incentives for our own livelihood to do that. But if everyone does what they want to do, rather than what is the most medically appropriate thing to do, we're never going to hit budgets, and we're going to have to keep cutting conversion factors. There's nothing constraining what any provider does, And so it makes sense that we can never hit our budgets, right? This is not that complicated. Again, we have a dosing problem in therapy. We're underutilized at the population level and on the individual patient level, broadly speaking. It's an overutilization of high-cost services that also build the physician fee schedule that are part of our budget. When you're doing too many MRIs and seeing too many orthopedic surgeons that don't need it, we can't maintain the budget, right? We are a tiny, itty-bitty fraction of that ecosystem. And just to keep in mind, it's a bigger problem. And the only solution is paying for outcomes rather than paying for as much as you can possibly do. That is not ever going to help anybody stay in a budget.
Yeah, no, I mean, for sure. I guess the caveat here is when forming a budget, it is really important to frame what is behind this budget, like where are the resources coming from, what is the justification, and what is that source of truth for the allocation. And so I think a lot of this budget constraints, it's a Sisyphus tale where you're just going to push the rock up the mountain to have it roll down indefinitely because it's year after year of the same type of a narrative without any fix, because there's no desire for fix, because the system is patched and broken but still continues to operate somehow. So right, it's like you are on that boat that keeps leaking water and you keep patching it with duct tape, but ultimately you're still afloat, so you're happy. And you'll just keep pedaling along deeper and deeper into the ocean, right? You can't see the shore anymore, but you keep pedaling and there's just more leaks and you are almost out of duct tape. And here we are. So without more duct tape, what do you do then? Like, do you then turn around and go towards the shore? Reset? There's been a lot of interesting actually writings, and maybe for the next episode I'll recommend this book, but there's the different schools of economics, and one is actually advocating for just imploding the US healthcare system completely, just disintegrating it and then starting from the beginning, because it's beyond repair. Like at this point it's not just on life support. The life support has ticked away and it's in that state that nothing is going to save it. But then how do you, like, who's going to be involved in restructuring it, and how do you restructure it, and what model do you use, and can this model be generalized to U.S. population? We're not a small country. We have a large, sick, underfunded population. There's a lot of different caveats. And certainly, if you look into some of our neighbors from the north that have a system working with a lot of critique and a lot of dissatisfied customers, but it's a system that works for that population of 40 million people. Can we build in a similar system with 370 million people with the high rates of obesity and chronic disorders? Or do we need to borrow from other countries that have a similar population or demographic of population that? So there's, I don't know, it's interesting that our conversation went this way where there's no one easy way to rebuild this process, but the process the way it is, like creating these like cuts and little nips here and there, it's like ultimately I guess it may be that they take it from one pocket and put it in the other, right? Like, and it just continue to play that pocket football. So
there's something to watch for in the next, I don't know, year, but something that's been spoken about that would be a shock to the system. But honestly, I wouldn't count anything in or out. There are thought leaders interested in taking apart the RUC. The RUC is almost all physicians, almost all MDs, majority are specialists. We've spoken about this. They advise CMS on which CPT codes should be made available and HCPCS codes, and what the weight of each of those codes should be, and what weight should they be as they're being used by different provider types. So there is interest in completely shifting what the RUC looks. One thing that would be a real paradigm shift, and what many feel has caused a lot of this, like, why do we have so much utilization of high cost services, is because primary care docs, they say it would take 28 hours in a day for a physician in primary care to do everything they're responsible for in terms of coordinating care, right? And documenting and communicating and all of the quality metrics, and everything's literally impossible. And so by shifting the payment and funding primary care more, which is what the advanced models of full risk are doing, part of that money gets used to build teams, which should include therapists. Again, I keep bringing it back to this. We know that significantly reduces the use of all of the other spend that happens because physicians have no time to go a step further and have a deeper conversation to avoid an MRI. Takes time that they do not have, because they have to be on this treadmill and they can't fund team-based care because they don't have enough income. So one way to change this completely, one option of the possibilities is to disrupt the ruck and change the whole system. And that could look 100 different ways, but that's one way to get there really fast. The other way is to mandate. Remember, CMS has this power. They could mandate an alternative payment model participation where they say primary care all has to take on full risk and they're going to get all the dollars. And then they are going to decide who they're going to work with. So there's lots of ways that they could play this. And I think, as therapists, to realize that a lot of this power sits with the Center for Medicare. And I know there's lots of other payers, but the most complex patients who seek our help the most are Medicare patients. They have more issues. Yes, there's lots of other payers, but other payers follow what the government payers do, follow those trends. And so keep an eye on that. These things could happen. They have the power to do these things.
Yeah, no, I mean, absolutely not. And I think this is probably for the sake of time. This is a perfect segue into that alternative payment model and defining it. And forgive me for reading this, but my memory is that of a middle-aged frog. So yeah, like there are 7 alternative payment models that can be classified into a physical therapy domain, but let's discuss 2 that are most applicable. So I'll just call out the 7 that are there. And the alternative payment model, the first one is payment for high value service. Second model is condition-based payment model for physician services or therapist services. Third model is multi-physician bundled payment, which is that payment model that you're referencing. The 5th is warranted payment for physician services, which is obviously something that you stand by your product or your service and offer some guarantees. 6th one is episode payment for a procedure, and the 7th one is condition-based payment. But I think the 2 models that we really should be discussing is a condition-based payment for chronic disease management, which I think is best related to physical therapy for what we do, because most of our problems are chronic and most of our problems are ongoing and don't have a single point of resolution. And the second one that we should discuss is episode payment for a procedure, and this relates a little bit more to that outpatient orthopedic physical therapy, which takes care of postoperative care. So tapping into that condition-based model for chronic disease, you essentially, a physical therapist will get a flat payment, monthly payment per life covered for a duration of an individual's life when they ensure guarantee specific engagement parameters for that individual. So someone who's had persistent back pain and has had it for X amount of years will then be covered for the rest of their natural life span. Part of the guarantee would be in-person encounters, part of the guarantee would be digital encounters, and part of the guarantee would be some of the other representation of clinical services, with patient also carrying the responsibility, right? The self-care responsibility, the reporting. So to me, I see it as a fully viable model because there is some certainty in that payment being received. A lot of the clinics that now are to like really volatile feast or famine mode, where they go from no patients in February and March to being inundated by November, like that's taken away. Somebody receives care when they need to receive care. You have checkpoints about the life of an individual. And the individual, again, themselves have personal responsibility to take care of self, or you have these digital systems that can be used for chronic disease management, where you as a owner of your chronic disease have a responsibility of being active, of finding proper nutrition, of monitoring your stable biomarkers, of keeping a healthy lifestyle. And then everybody profits because the system can reimburse well. You're not going to fall into this expensive low value care. So what do you think of that, Dan?
I think you did a great job of bucketing the different categories for therapists to think about from their perspective, because there's a whole lot of different ways that you can stratify alternative payment models, and there are really still so many in development. I will show you the system that the healthcare industry uses is by the HCP LAN, and the HCP LAN is the Healthcare Payment Learning and Action Network. So this is a private-public partnership. They take the interests of everyone and try to consider all of the payers' ways of approaching how they work with providers and what they offer in terms of alternative payments, with the goal being to get off of these category 1, and I'll explain these into the category 4. So this really is the super simplest way to think about how the healthcare industry and the payers think about payment models. The first being what we're used to, right? Just fee for service. You see a patient, you do what you do with them to them, and you bill for services. There's no link to quality required, no link to value. In category 2, this is like the most basic kind of, I would call it a pre-alternative payment model step, where you're getting something like care coordination fees. So you could have an insurer say, we'll pay you every month or every year X amount to do care coordination. Pay for reporting. So bonuses for reporting on certain quality metrics that they determine. Pay for performance. So just giving a bonus, not putting you at risk for performance, but just a bonus of performance, based upon how you do. And they look at the outcomes of your population. And then you move into the kind of the real APMs in my mind, where in category 3, you're providing care, but the care and the spend is benchmarked using predetermined actuarial systems to create a benchmark that establishes what you think of like a monthly budget for your whole population. You do your regular billing. Everybody else does their regular billing. I see my patients, you see yours. Who's ever actually taking the risk in this program, at the very end, the payer looks back and they say, okay, over the course of the year, as a whole, on average, you spent less than you did in the past for similar patients. And in that case, we're going to give you a bonus. Sometimes it can be very significant. Or if you didn't do a good job, you didn't manage costs or quality as well as you should have, then we're going to penalize you and you're going to pay us back. So it can be a seriously strong incentive to try to prevent spend that's outside of your own control and is more downstream and high cost. Then the last bucket really includes a lot of different things, but the HCP land calls it population-based payments. So essentially, the payer is paying prospectively, so they're paying in advance for the anticipated costs of managing a population. Sometimes this is higher than historical spend. They want them to invest in care coordination and team-based care, so they're just going to pay them a higher amount than they normally did so they can do that investment. And then they look back again, like in category 3, they look back afterwards and they compare the spend to what they expected. Everything is very transparent in this. Everyone understands how the parameters work, how the math works. Like, it's not in a black hole, or you don't get into contracts like this. Anyway, then they look back and they say, okay, you either did a good job and managed patients well and controlled spending, and patients' quality metrics were good, or you didn't do a good job and you're going to owe us money. When tends to be that when people get into category 4, they shouldn't get into this category unless they're very confident that they and their employers, everyone is willing to invest in strong team-based care and care coordination so that they can pull the levers to reduce the spend that's controllable. So that's things like preventing hospitalizations, preventing unnecessary use of specialists, preventing unnecessary tests, avoiding the ER, like more access to more hours, more urgent care. If you can provide those levers, you can predictably reduce the spend that normally you don't worry about because you're just billing for yourself. Then that's a really great option. And it's a way for, especially like primary care, but also can be used for hospitals. Put them in a full budget. That's being done now in Maryland and Vermont. You can do this for a condition specific. It's done for kidney care now. It's done in oncology. So those are your categories. It's like a continuum where you're moving from transactional up until full accountability for the cost and quality of care of your patients. Does that make sense?
No, that makes perfect sense. So each category is transitioning from the level, essentially risk and reward, right? Like that's the stratification. Those are the parameters. And the risk-based model will just try to shift the category of risk towards a high level of efficiency, which is your category 4, right?
Category 4 is not only the best way for the payers to get costs under control. Once you create this super strong incentive to perform better, and you can more predictably budget for less upstream spend, payers love to get providers successfully get prepared through categories 1 through 3 so that eventually they can move into category 4. And so the payers end up paying overall less, but the providers in outpatient settings should be earning more because the spend you're reducing is the inpatient acute spend, and you're reducing unnecessary tests, unnecessary specialist visits, that kind of a thing, right? So it's a win-win-win.
Incentives work when designed using the right levers and tapping into the generalizable psychology of a consumer. That the incentives don't work when they're prominent and they act as barriers. So incentives to nudge and to reduce friction, absolutely. Incentives to sludge and to increase friction will work to a point, but only for a short term, right? Like people have a natural aversion to sludge factors that increase friction. And so long term, like there's going to be a pushback, and that creates that volatile system of tit for tat, pendulum swinging one way, pendulum swinging the other way. So it's interesting. I think there's definitely a lot to digest here. I think certainly if maybe in the next couple of weeks we can go deeper into these alternative payment models and even create a structured diagram of how these models are formed and based, right, or present. But Dana, as always, I've learned a significant amount today. I think it's I guess at least in some cultures they consider the volatile and times of transition that carry the highest level of volatility, also the highest level of opportunity, right? So we just framing framing something that is potentially a barrier as a reason for reward, or framing that's an opportunity, right, rather than a problem.
One thing, Alex, as you made the categories 1 through 7, if you look at these categories, where do you see the way you framed it fitting into the categories 1 through 4? Or just a couple of the ones that you brought up?
Yeah, so I think that the category for payment for high value service, right, and a physician facility procedure bundle, like these are all categories that create a larger incentives of capping and controlling for the method of care provision. And so I think that the fewer variables or that are at play and the more controlled these variables are, the easier it is for you to pivot the system. You're going from disorder to order. And I think the order requires control, and control requires these capitation where multiple systems are being bucketed into one. But at the same time, again, to give you the counter argument, that there also creates a larger opportunity for fraud and larger opportunity for misuse and larger opportunity for withholding care, because there's now a negative incentive for dispensing care, right? And we've been through this before with an HMO crisis. It's just a relabeled process. We stick a different name to it, potentially. Continue to replay our history.
But we're linking, it has to be linked to quality. So if you reduce spend, but patient outcomes go down, you don't earn your money. You lose everything. The payer keeps it. And that's a distinct difference between HMOs and value-based care. Value-based care payment models require quality metrics being met. Now, the more outcomes-based they are, the better. But value-based care is only value-based care if you're reimbursed and incentivized for outcomes that are also the best choices financially. And you lose big if you do well financially, but patients don't do well. So there's that real distinct and critical important difference between what we did in the past and why this is actually working and reducing hospitalizations and reducing downstream costs.
I can definitely buy it. I think in the right principle and the right control, with a right position of labels of what the outcome is actually defined and proper stop points, it's a brilliant system. I think there just has to be both a general population agreement for these stop points and the providers themselves have to agree to enforce the quality measures. With that in mind, yeah, you got my vote. So
It's complicated, and we could do, we could spend 5 days just talking about category 3, for example. All right. But as an overview, and we'll link all of these documents in a nice framework in the resources database, which you can only have access to if you subscribe to our newsletter. It is a
now,
special gift you get for
definitely.
subscribers.
This has been wonderful, and I really hope that more people will subscribe. I really hope that more people will listen. I think every conversation with you, Dana, is a fountain of knowledge, so that I'm
Ditto.
lucky to drink from.
You too.
So happy and privileged to have this opportunity. So I look forward to the next multiple. Thank you for this. This has been great.
So much fun. I learned so much from you too, Alex. It's really great. And I love the questions. I'm getting questions from a super knowledgeable therapist. To me, that's representing what many other therapists are thinking and trying to make sense of, and helps inform the way I can better relay this to therapists and answer questions, right? And be able to better anticipate what their questions are.
Absolutely. Absolutely.
Yeah.
Just a representative of the people. So,
Right. Yeah, I love it.
awesome.